There are 3 node types to know, and if you know these 3, all your OSCE cases will fit one of them. For all types, we're going to use one helpful descriptor from our mnemonic, old cards or your mnemonic, Socrates or etc., in the first sentence of the HPI to focus our audience. So for a case of pain, the location helps focus the audience the most. For example, Mrs. Smith is a 50-year-old female with a past medical history of an appendectomy in 2020, status post-appendicitis, complaining of lower right abdominal pain. The lower right in the location, it's the most key or high yield from any of the old cards or Socrates mnemonic, and it right away helps focus the audience and gets them thinking lower right, maybe appendix, as we'll see below the different pathologies. Now, a beginner, or if you're just starting off, may tend to write the onset of her pain was, and the duration is, using the same mnemonic from old cards or Socrates. But a more experienced or more comfortable, if you're more confident way to say this is to replace the onset with started and the duration with occurs. So it's a more active form of voice. So her pain started and it occurs constantly or intermittently for, and then progressing from or previous episodes occurred. So we're getting all the duration, the onset and the duration right there. We'll continue with characterizing. And again, if you're just starting off, you may see people write their patient notes with the same abbreviations or mnemonics from the old cards or Socrates, but a little more advanced or a little more comfortable, we could write it in a more active form. She describes her pain. She's rating her pain, any radiation, aggravating and alleviating factors, and treatments tried. We'll use self-medication with. And then we end our pertinent positives and pertinent negatives. So again, if you're just starting out, you may see people write the pertinent positives are, the pertinent negatives are. But a little more comfortable, a little more experienced way is just writing also complaining of, etc. that started with her abdominal pain, and she's denying, any pertinent negatives. So in total, we could see a nice HPI could look like this. Mrs. Smith is a 50-year-old female with a past medical history of an appendectomy in 2020, status post and appendicitis, complaining of lower right abdominal pain. So her pain started, so we have the onset 2 days ago. We have the duration. It's occurring intermittently about 4 times a day with no known trigger, and it's been progressing from a 6 out of 10 to a 10 out of 10 now. And then previous episodes occurred of lower right abdominal pain were resolved after her appendectomy, status post or appendicitis in 2020. So she describes her pain as sharp or unbearable. She rates at 10 out of 10 and says it radiates around her back. Pain is aggravated by lying down and denies alleviating factors. So this is important and high yield as well, that we're seeing even if there are no alleviating factors or even if there are no previous episodes, we state the negatives. Writing the negatives is just as important as the positives. So we'll write denies alleviating factors. Self-medication with Tylenol had no relief. And then again, we see instead of writing pertinent positives are, we could say also complaining of feeling warm. Anytime there's feeling warm or feverish or hot, should be a trigger for some sort of maybe possible infectious etiology. Nausea and pain on urination. So we see again the importance of doing a good thorough review of symptoms, because now we have pain on urination, we should automatically be thinking some sort of urinary pathology. And that started with her abdominal pain. And then the pertinent negative, she's denying vomiting or change in bowel movements. So using our illness script for an abdominal case, a lower abdominal pain, we could pretty much rule out the abdominal columns on the left, because those would be accompanied by either vomiting or a change in bowel movement. For example, diverticulitis, we'll see constipation. Inflammatory bowel disease or irritable bowel syndrome, we'll see diarrhea or alternating constipation with diarrhea. Cancer, small bowel, we could see constipation. Intestinal ischemia, we could see diarrhea. So she's had no change in bowel movement, so we could sort of rule out our abdominal columns, but she does report on our review of symptoms change in urination. So she's having pain or increased urination. So now we could focus really on our renal cases. So I'd be very concerned. It's aggravated by lying still. She has to constantly move around. So be thinking very much so a nephrolithiasis, a urinary stone, or cystitis. She has a little bit of a fever. And also, since it's a female, we could sort of add in as well maybe an ovarian cyst or an ovarian torsion. So moving on to a case of bodily fluid, for example, a cough, hematemesis, or hematuria, any type of bodily fluid. It could be urinary incontinence. It doesn't matter, but any type of bodily fluid vomiting, we're going to use this technique. So for a bodily fluid case, the fluid color, that's going to be the C to characterize it, the A, B, C, and D, the color. It's going to help focus the audience the most. So for example, in a case of cough, Mr. Smith is a 50-year-old male with a past medical history of COPD, complaining of a dry or wet cough. So, if it's a dry cough, I'm immediately thinking maybe asthma, maybe CHF, maybe a URI, a viral URI, versus a wet cough. I'm thinking right away pneumonia, COPD exacerbation, lung cancer, pulmonary TB. So, and that's the same for any case. For example, for hematemesis, if it's bilious, I'm going to be thinking one thing. If it's just bloody, I'm going to be thinking another. So it shows the importance that if you were to think of the highest yield descriptor in that mnemonic, to really focus the audience and to intrigue the reader to start coming up with their own differentials, you would, a good answer would be the color, the characteristics of the fluid. And a beginner as well, if you're just starting off, you tend to notice that you may write the onset of his cough was, and the duration is. So we're using the same mnemonic as old cards, but if you're more experienced or more confident way of saying it is to replace the onset with started and the duration with occurs. So his cough started and it's occurring. We're really only interested constantly and intermittently, broad strokes. Is this, constant? Is it intermittent? We could, of course, write exactly the time, but that's, the big picture here. And then also, it's been progressing. It hasn't been progressing. It's equally important to say, as we'll see below. And any previous episodes. That's all part of the duration. So we can make a new submnemonic in our duration. CIPP, constant, intermittent, progressive, previous episodes. So, and then to characterize bodily fluid. So this is why it's a separate column. Any bodily fluid, we're going to use our mnemonic A, B, C, and D. So he's coughing, the amount we're going to write down, if there's any blood, the color, and the D's for odor. And then also severity. So if he's having pain while coughing, if he's having pain while urinating, pain and vomiting, pain on swallowing, any type of pain, we'll write it down as well. Any radiation, aggravating, and alleviating factors. And then treatments tried. It's the same from the previous side. And we'll end as well with pertinent positives, also complaining of, and pertinent negatives, denies. So in total, a nice HPI for a bodily fluid could look like this. Mr. Smith is a 50-year-old male with a past medical history of COPD, complaining of a wet cough. His cough started, so we have the onset, so it's a more active form of voice. Instead of saying the onset of his cough was, his cough started about 1 week ago, and it's occurring intermittently. Again, instead of saying the duration of his cough is intermittently, throughout the day, we're just saying it's occurring intermittently and has been progressively worsening. And now, previous episodes of cough occurred only after smoking, but this time seems to be worse. Okay, so we got down the basic onset duration, the same as a pain case, and now since it's a bodily fluid, we're going to dive right into A, B, C, and D. So he's coughing up about 1 tablespoon, the amount of white mucus, that's the color, and he's denying blood or an odor. So again, just as important as writing the positives, so instead of saying there is blood, there is an odor, even if it's a negative, it's just as important to write down those denials. And of course, it's a good idea as well to ask if he's having any pain on coughing or any pain on swallowing. So that's just, if same thing goes well if he's having bloody urine, any pain on the urination, if he's vomiting blood, any pain, anytime you have anything, it's good to ask about just general, has there been any pain? And now aggravating and alleviating factor. So his cough is aggravated by smoking and he denies alleviating factor. So again, the importance of putting down the pertinent negatives too. It fills up the space. It shows we asked, we're going to get credit, etc. And now our pertinent positives and pertinent negatives, again, it's in a more active form. He's also complaining of feeling warm. So just like the previous case with lower abdominal pain, feeling warm is infectious. So same thing here, if we see that, or if there's a fever that we're given on the vital signs, we should think of the infectious etiologies, and shortness of breath. So now we're thinking more of a lower respiratory pathology, right? He denies any runny nose or sore throat. So again, doing a good review of symptoms is important, because runny nose or sore throat would be concerning for an upper respiratory infection pathology. So I always like to include as well, the complete review of symptoms are below to show that we did ask everything. These are just the pertinent positives and pertinent negatives. So again, this is more lower respiratory. He's a smoker. He was diagnosed with COPD, and now he has new onset wet cough. So looking at our illness script for a cough, you could see the columns on the right side all for wet. He's having white sputum. So looking at the right columns, we could see, again, because he's having shortness of breath, it's a wet cough, it's going to be all concerning for lower respiratory tract pathology. And particularly because he's a COPDer, we're not going to write a differential of COPD. That's not going to be our differential. Our differential is going to be a COPD exacerbation. So again, you could watch the whole video for the cough illness script, but you'll see for an exacerbation, it's going to be increased sputum from baseline. It's going to be increased shortness of breath or dyspnea from his baseline. So that's important. He came in, he told us he has a differential, he has a diagnosis of COPD, so ours is going to be an COPD exacerbation. And again, of course, any wet cough with feeling warm, I'm going to be thinking of pneumonia. It's a wet cough. He has a little shortness of breath. It could be acute bronchitis. He has a history of smoking. It could be lung cancer. He's a smoker. It could be pulmonary embolism. Really, it could be any of the ones on the side of the wet side. And it just shows right away of having a good illness script, having it organized, and following the script for bodily fluid for A, B, C, and D, because it's going to break it down. Any case, it's going to be like that. For constipation, is it constipation with blood with hematochezia? Is it diarrhea with hematochezia? Automatically on our illness scripts for those cases, it's going to point us to a particular case. Now our final column is for any case that's an event, and so it's broadly categorized as really any case that doesn't fit a pain chief complaint or a bodily fluid chief complaint, and that is very broad. So it could include insomnia, it could be a syncopal episode, a seizure, an MVA, an assault, a hypertension follow-up visit, a diabetes follow-up visit, any case that's not one of the other two, essentially. And so for these event cases, the onset really is going to help focus the audience the most. So for example, Mr. Smith is a 65-year-old male with a past medical history of hypertension. He's on Lasix or furosemide, presenting after a syncopal episode that happened yesterday. So, we'd want to know right away, like, when did this happen? He had a seizure an hour ago, he fell and hit his head 20 minutes ago, or this happened, a week ago. Was he just in an accident, or was he in an accident, a month ago and it's a follow-up? Was he just diagnosed with hypertension, or is well controlled and he's been having hypertension for a while? So really having the onset provides a good context. So just to recap, in the pain case, we saw the key descriptor is the location for bodily fluid. It's to characterize the fluid, what it looks like, the color. And for an event case, it's, the onset. When did this happen? And to characterize an event cases, we're going to use our technique of pre, present, and post. So it's key. So any case that's not a pain or bodily fluid, use this technique of pre, present, and post to come up with some of the questions. And you could watch all the videos. You could watch the videos throughout the series. But just taking a look at a few examples for insomnia, for pre-sleep, pre-insomnia, we could ask, what's the bedtime routine? Even if you're on the fly and you don't remember them, just having this structure, this framework of pre, present, and post is going to help you right away formulate, your differentials and have what to write for your patient note. On the present side, if we're thinking of sleep, how long are you sleeping for? How many times are you waking up? What time are you waking up? And then post-sleep, after your sleep, are you feeling refreshed? Do you feel that you need to take naps? So, just on the fly, if you're coming up with this stuff, you're just breaking it down like that's going to help a lot. For example, a syncopal episode or a seizure episode. Pre-syncope, what were you doing beforehand? So do you remember what you're doing beforehand, before you had this loss of consciousness? And do you remember if you have any auras or warning signs? Were you feeling nauseous, sweating, palpitations? Before a seizure, did you see any lights flashings, or did you have any weird smells? Present during the syncopal episode or seizure, how long, were you seizing for? How long were you down for? And while you were down, it's very high yield and important to ask about these individually, because we could have one occurring without the other. So we always want to ask separately. One, was there any shaking? Was there any tongue biting? And was there any urination? All three of those. And then post-syncope or post-seizure, did you have any sensory numbness, motor weakness, or confusion after? And again, it's high yield and important for these cases that we ask about these all individually, because you could have one without the others. Or for another example, for a case of an MVA or an assault, before the MVA, before the assault, do you remember, tell me a little bit about, what was happening, how fast were you going, what car were you driving, where were you? Or for an assault case, tell me about the assailant, were you in a relationship with him, do you know who he was, etc. And during an assault or during a motor vehicle accident, or did you lose consciousness? If it was an assault, was it sexual as well, or was it just physical? If it was sexual, was it oral, was it vaginal? So you could kind of come up with these on the fly. If just knowing the framework is the main thing. The framework is going to teach you really how to reason through the case instead of memorizing, all these questions and all these cases. And now for post-MVA or post-assault, we want to know, do you have a support structure? Do you have any, if it was an assault, do you have future plans to maybe live with a friend or, find somewhere else to stay in the meantime? As another example, or you could watch the videos as well to see all the cases, but for example, hypertension or diabetes, for pre-hypertension or pre-diabetes, let's do it on our own here without any answers. We could come up, when were you diagnosed? Before you were given the hypertensive or diabetic diagnosis, when was that? What was your blood pressure at the time? What was your A1C at the time? Presently, okay, you have the diagnosis. What are your current readings? Do you take a log? Or do you have any medications that you're currently on? So we could see we're just coming up with these, posts, and then do you have any complications from your diabetes or your hypertension? Are you having any trouble seeing, any numbness, any tingling? So again, it's a very good framework if it doesn't fit a pain or bodily fluid case to use that technique. So a nice HPI could look like this. Mr. Smith is a 65-year-old male with a past medical history of hypertension on Lasix or furosemide, presenting after a syncopal episode that happened yesterday. So we have the onset. It puts it in good context and good framework. Okay, this sort of just happened. Maybe I'm thinking a little more acutely, etc. His syncope occurred after rising from the couch. So this is the pre, side where we have what to write about because we have this technique or framework. After which he remembers feeling lightheaded and falling down, but he denies any auras. And now we have our previous episode, so he's denying previous episodes, but he's saying he does recognize or feel more lightheaded the past couple of weeks. He says his son told him, right, because he had a loss of consciousness, so we could ask him if anybody was around, and he's saying yes, his son told him that he lost consciousness for about 1 to 2 minutes. So we have the present. So during his loss of consciousness, he was down for about a couple of minutes, and he did start to shake his arms and legs, but there was no tongue biting or urination. So again, it's important we ask about it individually, because he could just say, yes, I had seizing activity, but we wouldn't get the full details. And then after regaining, so we have the post technique or post framework, he denies any side effects, essentially. No sensory numbness, no motor weakness or confusion. And now for our pertinent positives, he's saying, yes, I'm also complaining of palpitations. So again, it's very important to do a good review of symptoms, but he's denying any change in vision. So, if he has a change in vision, yes, that can make you dizzy, that could make you maybe fall down, etc. And then a complete review of symptoms is below to show that we asked everything, and this is just the pertinent positives and pertinent negatives. So an elderly man, 65 years old, he has a past medical history of hypertension with a syncopal episode. Let's take a look at our illness script for a loss of consciousness or for a seizure. And primarily based on our history and his risk factors, we're going to be looking in the middle column under the present side for cardiac etiologies, right? Not really neuro, not really vasovagal all the way on the left, because there were no auras. He doesn't report having any change in an autonomic drive. And you can watch a full video to see all the supporting points, but there's been no change in an autonomic drive for generalized tonic-clonic seizure, okay, he didn't have any tongue biting, he didn't have any urination. So, in a TIA or a stroke, we'd expect to have some motor weakness, some sensory changes, some confusion. He didn't have any of these signs or symptoms. An intracranial mass, he'll have maybe some change in weight. He'll have, he didn't report that in our review of symptoms. That wasn't there. So this leaves us in the middle column. For the cardiac etiologies, cardiogenic syncope, yes, it's going to be high in our differential. Why? Well, he noticed feeling palpitations, a little lightheadedness. So maybe we're thinking he has an arrhythmia. Maybe as he's getting older with a history of hypertension, his heart, he has some cardiomyopathy, issues. And also convulsive syncope. Why? Because he was seizing. So the pathology in a convulsive syncope is just if the brain, if the heart's not pumping, there's a blockage, there's an arrhythmia, whatever, the brain's not going to get enough blood flow, it could go into seize. And the key differentiating between a generalized tonic-clonic seizure and the convulsive syncope, there's going to be no postictal state, right? He didn't have any postictal changes. He was fine afterwards, right? And also we're going to be thinking about orthostatic syncope because he's on Lasix, he's feeling lightheaded. So, from our history and from our HPI and our technique of pre, present, and post, we're able to very accurately plug from our illness script and especially for an OSCE, these are going to be the differentials. So we hope this framework of writing your note based on either being a pain and writing descriptors or a bodily fluid and including the A, B, C's, and D's of the fluid, or an event using the technique of pre, present, and post to frame your questioning and to get the details is helpful. Thank you.